overview of expectations of a medical billing service. My name is Randy Curran, and I run our billing service for Nierman Practice Management. And I've been doing medical billing in respiratory and sleep and then in the dental field for the last 9 years. So I want to share some of my knowledge and give you guys an overview of what you should expect, whether you're using Nierman Practice Management as your billing company or any other company as your billing company. So go ahead, Courtney, next slide. Or can I just push this here or no? Because I have a little button.
Yeah, but nobody else will see it, just you.
Oh, okay.
If you want to come back up.
That won't be good. So first thing here is verification of benefits. We want to go through verification of benefits, also known as insurance verifications or breakdown of benefits. The standard, we know as a billing company, this is very important to our clients. The standard that you should have your benefit of breakdowns back to you from the time you send it to your billing company should be 24 to 48 hour period. Normally we'll say same day, next day, because you are at the mercy of the insurance. If the insurance is closing, it's hard to get them back the next day. But if some billing companies may get them that morning and be able to turn them around same day, and that's our goal here. So, but at the minimum, you should expect when you're working with the billing company that you're getting those benefits back within a 48 period, so that you have an opportunity to get your patient in as soon as possible as well and understand what those benefits are. So that's the first point, and the first step is being able to get that benefit breakdown on every patient that you send over to your billing company within a timely manner. And I think 48 hours is a good time for that. The small details you should expect and need when you get that verification of benefits. The first one would be the DME max. And these are the small details besides just a basic verification when you're getting the co-insurance, the deductible. But these are some other things that you should be looking for when you get that benefit breakdown. The DME max. That DME max means how much a plan would pay, a maximum payment they would pay out of pocket to the patient. So it's real important to understand the DME max. If you get your breakdown of benefits back from your billing company, or even if you're doing this yourself, it's key to understand that, because some plans, and I would say most of them don't, but you do run into some plans sometimes that will have like $1,000 DME max or $1,500 DME max, meaning that's all that patient's plan is going to pay for out of from the insurance company. The carrier is only going to pay $1,000 to $1,500, whatever that may be, and that's it on any durable medical equipment. And the other thing you should look for in that, if there is a DME max, is to ask your patient if they've been on CPAP during that year, because when you call into the insurance, they're not going to tell you what's been applied to that DME max like they do. They'll tell you what's been applied to deductible. They'll tell you what's been applied to the patient's out-of-pocket max. Well, with the DME max, it's very unlikely they're going to tell you what's been applied. So you want to ask your patient, find out from your patient, so going into it, if there is a DME max, that something can hit that DME max. For example, if a patient comes off of a CPAP, that means that CPAP, if it's billed within the same calendar year, that CPAP and the CPAP supplies have been applied to that patient's DME max. Or other DME durable medical equipment. Could be if they were on oxygen or had a wheelchair or had crutches or something like that, then you may want to ask them if they had any equipment throughout the past year like that. But especially what we mostly run into is CPAP intolerant patients. If a patient's coming off of a CPAP recently and they do have a DME max, you need to take that into consideration, because that CPAP and the CPAP supplies probably ate up most of that DME max. So then that patient could become just a straight out-of-pocket patient. The next thing on here is max out-of-pocket. If the patient has their insurance will have a maximum out-of-pocket both in and out of network, you want to find that out of the gate, because if, especially this time of year, if that patient's close to their max out-of-pocket, then it's easier to capture that patient and be able to convert that patient into an oral appliance or TMD therapy, whatever it is, because, for example, if the patient's in-network out-of-pocket max is $3,000 and they've already hit $2,800 of that, and you are able to get in-network benefits like gap coverage, which we'll go into, that means the patient's only going to have to pay $200. So their deductible's probably been met, and even if they have like a 20% co-insurance and you billed and they allowed for, say, $3,000, and maybe normally that'd be a $600 payment cost portion to the patient, well, because they're close to their out-of-pocket max, that's only going to be a $200 pay cost to the patient. So it's a big difference to the patient to understand that that they've almost hit their out-of-pocket max, or maybe they have hit their out-of-pocket max, and everything that's going to come payment-wise to the provider is going to come from the insurance. And again, early in the year, that usually doesn't apply too much unless somebody has something big happen. But later in the year, we see it quite often. And going September to right now, you know, we personally have probably about 10–15% of our patients that we've been processing, they've met or very close to their out-of-pocket max to the calendar year. The next thing you want to look for, and it's a big thing that a billing company should do to maximize your reimbursement and to minimize the patient's out-of-pocket cost, is the gap or in-network exception available. And there's two different ways this is going to help you. And the first way the gap's going to help you is going to be if the patient comes to you and they have a PPO insurance, and they may have in-network benefit coverage at a $500 deductible and 80/20 on the co-insurance, and then maybe a $1,000 deductible out of network and 60/40 on the co-insurance, and maybe $200 or $300 been met in-network, and it's not a combined coverage plan, so the in-network doesn't go to the out-of-network on the deductible side, so nothing's been met on the out-of-network deductible side. So you want to make sure that your billing company is doing everything they can to get gap coverage in those situations. Many policies will allow gap coverage if there's not a provider within like a 25 to 30 mile radius, depending on what the policy states. But they will allow it, and it's going to make a big difference for your reimbursement and your patients out of pocket. And again, that goes back to being able to, and I call it capturing patient, you know, they call it retention, whatever, but I call it like a patient capture rate, that you can capture more patients coming into you when you can get past that financial hurdle. So if you can get that gap coverage, and all of a sudden, instead of that patient having a $1,000 deductible and a 40% cost share to you, now they only have maybe a $200 or $300 deductible left on their in-network benefit level, and also their co-insurance is going to go down to 20% versus 40%. So the patients out of pocket could be tremendous. Could be a tremendous difference if your billing company can fight hard and go for gap when available on every patient. It could be anywhere from $800 to $2,000–$3,000 difference, whether the patient, if you can get gap coverage on that or not. And that will maximize your reimbursement as a provider and also minimize that patient's out-of-pocket cost, therefore you know, getting more patients to move forward with the procedure. And also, not only that, that patient, the best referral is a patient referral to their friend or family member or things like that. So it's also a great way. If you have a good system in place and your billing company is working hard to have that done, that means that patient goes out and tells their friend about the therapy, and the therapy is great, and you know, they're feeling better and everything. But they can also say, yeah, it only cost me $500, it only cost me, you know, $700, as opposed to them saying, yeah, it's good, but it cost me, you know, $2,000–$3,000. That makes a big difference of how many patients are going to be referred back to you through word of mouth coming back in. So anytime we can minimize the patient's out-of-pocket cost, not only is it a great thing for the patient, a great thing for the provider to capture more from the insurance company, but in the big picture of it, it's also good that patients are out there speaking about, you know, the treatment and the financial responsibility that they had towards that treatment in a positive way. The in-network exception available, That's another term, so you want to make sure that one of those terms are offered. A lot of times the insurance recognized an in-network exception is when a patient has an HMO plan. And if the patient has an HMO plan, again, you can get coverage for that patient most of the time. So, and a lot of that term, the in-network exception, is whether the network, these HMO medical and carriers that we work with, they will understand that terminology and will ask for a one-time in-network exception because there's not an in-network provider in the area that offers treatment for whatever that treatment may be. And there's different ways you can get that. Sometimes it's a little bit more difficult because it's an HMO, and sometimes that has to be go through a typical HMO process where that in-network exception approval has to be generated by the patient's primary care provider. Meaning that, like any typical HMO, if you're familiar with HMO, if you had HMO in the past yourself, you go to a doctor and you need an x-ray, maybe you think you broke your hand or something, and you need an x-ray, that primary doctor needs to submit a referral to get that authorized before they can just send you down the street to get the x-ray. So it's kind of the same process with the in-network exception as well. The billing company that you're working with will call, and probably half the time, or maybe 30 to 40% of the time, they won't be able to they won't be able to get that in-network exception by themselves. They'll need the primary care to get involved, and that's as simple as having that primary care doctor for that patient submit a referral to the insurance with the dentist NPI and the dentist tax ID, so it goes into the system that way. Once it goes into the system that way, the billing company can then call back once they know that primary care physician's put that in. The billing company can then call back and request that in-network exception to go through, because now it's been generated the way most HMO referrals go through, and now it's going the right way through the process. And then now, if they get that approved, you can now see an HMO patient, which you wouldn't otherwise be able to see. And that's going to make a big difference, too, in your marketing standpoint, is the more insurances you can take, not only are you going to be able to see patients, and then, again, back to the capture rate, I can see an HMO patient if you have the right billing company working hard to get these things for you. You can see this patient, and again, not just can you see this patient. We go back into the marketing aspect of it. Now, when you're out there marketing your practice, you can say basically, yeah, I can take HMO, I take PPO, I take HMO, knowing that you're getting in-network exceptions on those HMO patients. The other thing on that too, once in a while, the patient may have to also generate that gap coverage or in-network exceptions. So sometimes you may run across a plan, and we run across a plan that says, yes, it's available, but this needs to be initiated by the patient. A good billing company will get involved with that. They shouldn't just send you back, yes, here are the benefits, and it needs to be initiated by the patient. Well, what a good billing company should do is offer a three-way call where they're getting involved and doing everything they can to get that patient to move forward with you and be a true partner in this with you. And what they will do is do a three-way phone call, because if you just tell your patient, yeah, you can get coverage on this, or yeah, you can get better coverage and use your in-network benefits if you call and do this. Well, the chances are the patient's not going to do it, or if they do it, they're not going to know the right things to say. And they're going to get a rep, and it's usually not going to go very well, and probably won't get done. So a billing company that's a true partner in this with you would offer a three-way call. So the patient, the billing company, the way we do it as a billing company is we call the insurance, we go through the whole process, get all that. We ask the patient to have a window of opportunity that we can call them that they're available. We get the rep on the phone, then we patch the patient in, and then they would do it like that. So the patient, the billing company, and the insurance representative would work together to initiate that gap coverage. And that seems to be very successful most of the time too. And especially sometimes, insurance reps aren't the friendliest to billing companies or providers But it's a different, it's funny, it's a different mentality when they get on the phone with their member. And that brings it all together, and it helps that process get approved. The next thing they should always know, if there's listed contracted providers and have they been called, when you ask for a gap coverage or an in-network exception, and you're dealing with the insurance company and they say, yes, we do have a contracted providers in your area the patient can go to, so no, we're not going to approve a gap or in-network exception. Make sure your billing company is taking the next step, because most of the time, and I think probably 95% of all the clients we work for, there's no in-network providers within that 30-mile radius. So most of the time you don't run into that. And if they do give you some in-network providers, you're still open there. It shouldn't be a closed case. What should happen, the next step that the billing company should do is to call those listed providers that they've given. So say they give 3 listed providers in the area that treat oral appliance or TMD or whatever it is. They may not be in network for that specific procedure. They may be in network maybe as an oral surgeon and you're checking for DMD benefits. They may be in network for oral surgeon and you're checking for sleep apnea benefits. So you need to call, the billing company needs to call those providers and confirm, ask them, what they do that treatment, even ask them what devices and appliances they use, because sometimes you get that front office person and they go, oh yeah, we do that, and they're thinking sedation or something, and that's not the case when you talk to them about treating sleep apnea. So the billing company should take that extra step and confirm that the contracted providers in that area that the insurance is giving you truly are offering the treatment that you're trying to get gap coverage or in-network exception on. If they aren't, and you've called all of them and they aren't, you call back the insurance, and the insurance carrier did their due diligence and they've offered out what they're supposed to do contractually and send their members to in-network providers. And you tell them that, look, I understand that you have these providers in the area. We wanted to send our patient to those providers. We were going to send our patient to those providers to help the patient, maximize their in-network benefit. But these providers don't offer the service or the treatment that the patient needs and that we are requesting the gap coverage for. At that point, the insurance company will either give a couple other providers, or a lot of times they'll just go ahead and approve it at that point. So just make sure the billing company you work for, that's working for you, isn't just giving up as soon as they know that there's contracted providers in the area. There should be at least another follow-up step to that to ensure that those providers that they show in network truly do offer the service that you're requesting the gap or in-network exception for. The other thing, pre-op needed, they need to make sure that there's a pre-op needed every time, because you'll be dead in the water if they make a mistake on that. If they don't confirm that there's a pre-op needed or not, and you move forward with the claim, and you submit that claim and there was a pre-op needed and you didn't put that pre-op number on the claim, it's not going to be processed. And now you gave a patient something that you're not going to be able to get paid for because the date of service is prior to the time that you're going to get the pre-op. So that's a big deal to get that as well. Man, it seems like I spent a lot of time on that slide. I might not be on the right page. So anyway, here's the next slide. Here is the sample of a benefit breakdown. I just wanted to show everybody. And you can see here, this is one that we use in-house, and I'll run through this pretty quick. The procedure codes that we verified on this one would be an oral appliance and a sleep study, a home sleep test. And then you go down to the deductible here. You see the in-network deductible that's $500, and deductible met at $334. Out-of-network deductibles at $1,000. Nothing met. And what this is, and we see this a lot nowadays in insurance is going to, a few years ago when I was doing this, especially like 5-6 years ago, I see a lot of combined deductibles where if you spent $300 in-network, that would apply to your out-of-network. Insurances are moving kind of away from that to save costs for them and put more pressure or more out-of-pocket costs to the patient. So you see this is not a combined deductible. Sometimes there'll be deductibles where out applies to in, but in does not apply to out, meaning that if they pay the out-of-network deductible, it'll apply to the in, but the in doesn't apply to out. This, what we're looking at here, is a very typical situation that we come across where they're not combined. So you have $1,000 there on the out-of-network side with nothing met. Your co-insurance is 80/20 versus a 60/40. The out-of-pocket max is $2,000 in network, and this was done early in the year. For example, only 458 met, and 4,000 on the out-of-network side with nothing met. This is one that, and this is what you see up here, I skipped past, it's United Healthcare PPO plan. This would be a typical one you really want to get gap. So you look on the far right over here, and everything we go through when we're on the call with the insurance company is answered here. And this is why you can't just, your billing company, if they're sending you back a benefit breakdown, it can't just be done through an automated system. You can't just go on the IVR. You can't sign up for Availity or, get the 270, 271 benefit breakdown back to you just through a generated system, because it's not going to give you all these details, and you need all these details. So you see the DME max. There's no DME max on that. Gap available. Yes, gap's available. Notes on the gap. There's the phone number and the option. 30-mile radius on that one. Is it pre-authorization needed? Yes, the pre-auth is needed. There's also a contact number there with the same, it looks like it's the same one on this one. So there's option 3 to request the gap coverage and the authorization. So it's going to go through the same department. It's going to go through the utilization department, and they're going to, approve that. And if you see the contractor providers, there's a yes on this one. If so, who? And again, that's why I said, we have Larry Smith and Doug Jones down on this one as samples that we would call and confirm that they do the procedure, that they treat sleep apnea, and they bill for E0486. So that's a basic benefit breakdown that you see. People have different forms of it. Different billing companies will have different forms. We've gotten ours down to one sheet, and so all the key items that you need to know are on that one sheet, and all the important stuff that I just spoke about is all covered for that benefit in the provider, or for the patient and the provider. Next slide. Gap or in-network exception is the one, we just kind of talked about, to receive payment based on the in-network benefit level. We don't need to talk anymore on that. I think if you guys have some questions at the end, we can answer that, but it's pretty straightforward. Usually approved when no contracted providers are within a 30-mile radius of the patient's residence. And again, it doesn't go off of where you're located. It goes off where the patient's address is, and that's so they check their system. And some are 25 miles, some are 30 miles. I've been on the phone. I've done some 3-way calls with our patients, and it was a Blue Shield federal plan trying to send a patient like 75 miles away or 80 miles away. And I've seen some that'll try to do that, and some of them, the policy will say 50 miles even. And you have to fight for it. The billing company has to fight for that. They have to remind the representative and the representative supervisor eventually that this is it's like in this case, this would be a sleep-deprived patient, and you're asking this patient to drive 40 or 50 miles or 60 or 70 miles. I've seen some have to drive to like major cities like Seattle or San Francisco or whatever, and it could be well over a 100-mile drive, and that's not right. And when you're on the phone, when your billing company's on the phone with the insurance carrier, those calls are recorded. So what we do here is we always remind the insurance carrier that it is a recorded phone call. And you are asking your patient that they would drive in excess of 25 miles, even though they're sleep deprived. So that's general rule, 25, 30 miles. Sometimes I've seen 50, but you got to fight for it if it's beyond that 30 miles. Contracted providers, given usually don't treat sleep apnea, call should be made to confirm that. We touched on that earlier. Why is it important for our billing service to obtain this? How will this benefit the provider? How will this benefit the patient? Again, every billing service should obtain all that information, and because it's going to maximize your reimbursement as a provider. And you say you take this times, you're seeing 5 to 10 patients a month, and you can put an extra $800 or $1,000 for every one of those patients to your bottom line. that's an extra $5,000 to $10,000 that you wouldn't normally receive from the insurance, and it would be passed on to the patient, and that's more difficult to collect. So it's going to help you with your bottom line. And again, the big deal is it's going to help you treat more patients out there. The more you can use the patient's insurance, the more patients you're going to treat, and the more people you can help in your community with whatever they need help with, whether it's TMD, sleep apnea, oral surgery, whatever it is. The more you can capture that patient's benefits, the payment from the insurance company, that means more people treated, which is what we're all here for in the first place. And then, well, I don't need to go through this too much, but I'll real quick, like that Joe sample that I just showed you. Just a quick scenario on that is, say that on those exact benefits we looked at, a $35 allowable for that sleep appliance, say the insurance allowed $3,500 on that. With gap coverage, Joe would have paid $832.80, and the provider was paid $26.67 from the insurance. Without gap coverage, on that exact same scenario, Joe pays $2,000, his complete deductible, and the co-insurance involved with that. And then the insurance would have only paid $1,500. So you can look at that in that example. And again, that's a very typical insurance we see all the time, that benefit breakdown we just put up there. That's pretty standard. That you could see that that's going to cost Joe, $1,200 to move forward with that treatment. And is Joe still going to move forward with that treatment if it's going to cost him, $2,000 versus the $800? So last thing on that is, that's the bottom line, is do everything you can to maximize the insurance payment and minimize the patient's out-of-pocket. HMO plan, we talked about that too. The patient is able to get coverage and able to obtain treatment from the dentist they choose. If you can get that in-network exception, you can keep that patient. The patient can stay with you and not go over to another provider that the patient probably doesn't want to see. They want to stay with their dentist. Medicare and supplemental insurance. Medicare should also be checked. Your billing company should be checking Medicare as well. What you run into is, if you don't assume a Medicare patient is ever a Medicare patient. A Medicare patient can come into you and say, hey, I'm a Medicare patient, and they may think they're a Medicare patient, but somewhere down the line, they've converted their Medicare and their typical true Medicare insurance to a replacement plan, like an AARP or Medicare Advantage plan. And there's so many out there, and I'm sure you guys have heard the commercials, or late at night, hey, call us, we can reduce your drug costs if you come with this plan and this and that. So I'm sure you've experienced that, Courtney, where people have said that. And
Absolutely.
Not the case.
Yeah, and I can even tell you from personal experience, you'll hear people say sometimes that Medicare patients sometimes don't even understand that they've given up their original Medicare and signed up for one of the replacement or Advantage plans, as they're sometimes called. And my grandpa, exact same thing. He had no idea, but he's got an AARP Advantage plan.
Yeah, they don't. Most of the time they don't, and I've dealt with that firsthand too. And I've learned the hard way years and years ago, because what happens is, a patient comes in, they say they have Medicare plan. If the billing company isn't calling Medicare to verify that Medicare is that traditional original Medicare is their true Medicare, and they treat the patient right, because Medicare, you don't need an authorization with Medicare. You can treat the patient as long as you have all the necessary documentation. You can treat the patient because no author is needed. By the time you treat the patient and you give the patient the appliance and you send in the claim, you get a denial saying, sorry, Medicare is not primary insurance. We are not their primary carrier anymore, because that patient has converted. And now what will happen is, since that patient has converted, the patient has the appliance, they have an HMO, Medicare HMO is typically what they convert to, and that HMO needed an authorization. So now you're dead in the water as a provider, because you just gave a patient something that you cannot bill for because you didn't get the authorization. And that happens more often probably than people think, because, again, like Courtney's saying, most of the Medicare patients, they don't even understand they've changed Medicare. They still assume that they're Medicare, and they'll tell you, yeah, they're Medicare Prime. They won't give you the new HMO card. They'll give you their old Medicare card and say, oh yeah, here's my Medicare card. Is my social on A or B or whatever.
Yeah, I'm sure the Advantage Plan sales guy tells them that in the fine print, right?
Yeah. Yep. And so what the billing company needs to do, they need to be disciplined. Every Medicare patient that comes over, never assume that patient truly is a Medicare patient. They have to verify, and that one is pretty simple to do because you don't have to get the gap coverage and all that, straightforward. But the billing company that you're working with or going to work with, they should verify eligibility on every Medicare patient before they give you the green light to treat the patient. Because again, what I just said, that scenario is a bad situation. If you treat a Medicare patient that isn't truly a Medicare patient, you didn't get an authorization. Now, is that going to be a billable item through their HMO because the pre-op was needed? No. Now you didn't get the pre-op. Now you're dead in the water because that verification wasn't done to confirm it's a true Medicare patient. So that's a big deal that the billing company checks on all those Medicare patients, and that the provider understands they have to get that to the billing company to check. Don't just assume, oh yeah, here's another Medicare patient, we're good to go. We have the sleep study, we have the doc notes, the face-to-face, we have the RX from the medical doctor. That's great, but make sure that truly is a Medicare patient.
Right, I think that's a super important point, Randy, too, because I do see that, especially with new dentists that are new DME suppliers, it's a very easy mistake to make to assume it's a Medicare patient, and it's really important for the providers to understand that if it's not original Medicare, it's basically treated like a private plan or an HMO plan. Is that pretty much accurate?
Yeah, it's accurate, and I learned the hard way years and years ago.
Yep.
I learned the hard way myself. So definitely know it firsthand. It sucks.
I hear you.
And then the supplemental should also be checked if the patient does have a supplemental insurance, especially at the beginning of the year. The supplemental insurance that a patient has, some people always call it secondary, but they're truly not secondary. They're supplementals, but the general knowledge. So if you're speaking secondary or supplemental, check the benefits on that too, because don't think you're going to get paid by the supplemental when there's a deductible sitting on the supplemental. Beginning of the year, that supplemental can have a $1,000 deductible or $500 deductible, and nothing's been applied to it. So you're not going to get that 20% or whatever from that supplemental until that deductible's been met. So they should be checking the supplemental for you too, so that you have a good understanding of what you're really going to be able to collect on. Next, coaching. This is a big thing that I've worked with other billing companies and heard of other billing companies and have some familiarity with them. This is where you really want to make sure the billing company you work for does the coaching. They help you out. Insurance verification, the way it should be done is the insurance verification, or you call it breakdown of benefits, or whatever the term is sent back to the provider. Coaching and educating should be standard practice. So when that benefit breakdown comes back to a provider, especially if they're new to treating medical and dentistry, they don't understand what that means. They may understand the basics of the deductible, but they don't understand the in and out. They don't understand if it's a combined deductible. They don't understand if there's gap available on this. They don't understand what they mean by maxed out of pocket. So a billing company can just go, okay, great, here's your benefit breakdown, send it back to you, but does the provider know how to read that? And more importantly, does the provider know how to relay that to the patient that's coming in for the financial consult? That's been from the practices that I've worked with, especially the newer ones, and even the older ones, even ones that we work with that do 30 plus appliances a month. They still come across some tricky insurances. But especially the new ones that aren't doing this, is they may be doing 5 to 10 a month, or even less. How do they know what to tell the patient what their out-of-pocket cost is going to be? How do they know what to tell the patient, what the insurance is going to cover, and how do they know internally what that's going to be? So there should be coaching involved. There should be, you send back the benefit breakdown, and here's the benefit breakdown. Call your account manager and find out, go over the financials. It takes 5 minutes to do. And at the same time, that practice is really learning, okay, now I understand this policy. And you're not going to know the answer to every one. An out-of-network provider is never going to know, hey, it's not like, dentistry where you know a straight-up answer, here's the cost, and here it is, black and white. It's not. But you can get good at it, and you can start to understand policies in your area, the better insurance is. And the staff, like the staff that we have so much experience that we can look at policies, look at insurance breakdown, and basically tell how it's funded. And how a policy is funded is going to usually be a predication of how the policy is going to pay out. So you can look at, and then we also obviously knowing the basic of, okay, is it a Blue? Probably doesn't pay that well. Is it a United? Oh yeah, it's going to pay pretty good. Or if the Aetna is going to pay pretty good, they have better usual and customary on the allowable. But that's what a good billing company is going to do for you. They're going to send you back that benefit breakdown and review that benefit breakdown, and at the minimum, at least give you, hey, this is the estimated out-of-pocket cost for the patient. They have the deductible sitting and co-insurance, and based on what you charge out, you should collect $600 as an estimated out-of-pocket cost of the patient, or maybe $1,200, depending on how you think the policy is going to pay versus your charge amount. That basic coaching makes a big difference to the provider, whether they can go into the room and comfortably relay the financials to the patient in front of them. Because if you want a patient to move forward with this, the doctor usually does a good job going over the treatment of it and going over the ramifications of not being treated with it. So you do that, and the patient's, okay, I'm ready to go. I know I need this for my health. It's important to my family, important to keep my marriage, whatever it is, I need to do this. Now it comes into the financials. You want to make sure that the person in your office, in your practice, that's face-to-face with that patient is very confident, or at least confident enough by the coaching to say, this is what's going on with your insurance, these are your benefits. You don't have to complicate it, because the patient just basically wants to know, what's it going to cost to me, So you're not going to go over all of that. You keep it simple with the patient, but give the patient a good estimated out-of-pocket and explain to them how much, your deductible still has this, and you have some co-insurance, and this is your estimated out-of-pocket. And it should always start as, when you're doing that conversation, it should always start as, hey, great news, Mr. Smith, we called your insurance, and your insurance does cover this benefit. That should be the starting of every conversation that financial consult starts with, that person in your office is speaking to the patient. It's, hey, great news, they covered this benefit, So now it's wow, it's okay, my insurance does cover this, and then you give them, and your estimated out-of-pocket is only this, versus if they were a cash pay. It should always be spun that way, so that the patient knows it's a positive thing, that they have the coverage, and now here's the out-of-pocket cost for this. And hopefully it's even a good out-of-pocket estimated cost. Maybe it's a minimum out-of-pocket cost. But even if it's $1,200, if it's spun the right way, and tell them, great, you have benefit, you have benefit coverage for this. Normally this is a cash, this procedure is like $3,000. It's only going to cost you $1,200 or $1,400, even if they're sitting on a big deductible. So even if they have a $1,200 out-of-pocket cost, if it's presented to them in the right way, it's going to be a positive thing for the patient, and then this patient will probably move forward. So a lot of coaching is needed, in my opinion, from a good billing company to help you grow your practice on the medical side of billing or your medical side of your practice. Insurance coverage dictates the path of a sleep study referral. I'll talk about this rule on the sleep study side. Another mistake is a lot of practices that we take over, they've been with billing companies, or they've tried to bill it themselves. And I'll ask them, say, okay, where do you send your, and I get a feel for the practice, how do you do your sleep testing? Where do you send your patients if they need a sleep test? So you're screening your own patient, great, you're doing a great job screening your own patients. Everyone's filling out a stop bang, everybody's filling out an Epworth score, terrific, everything sounds great. When you have these patients come to you, and now they say, that you want to test them, you want to screen them, what do you do? What's your next step? Well, we send them all to the sleep lab down the street. And I'll say, oh, okay, that's terrific. You guys are working with the sleep lab. That's incredible. And they're oral appliance friendly. That's great. Are they in network or out of network? Most practices don't even know. So, for example, what could happen is if they send everything to the sleep lab down the street, that everything is in network, and 30% of the patients they see, they can't get gap coverage and they have to bill out of network because the policy doesn't allow it, or they may, whatever the reason is, that means 30% of their patients are paying to go have an in-network sleep study done, paying deductible on the in-network side. Then they come back to get the treatment for the oral appliance for the sleep apnea, and now that deductible is still sitting there on the out-of-network deductible. So they may have paid $500 cash for the sleep lab to meet the in-network deductible, and now coming to you, and because that went to an in-network sleep facility for sleep testing, and you're going to have to bill this one out of network, now that patient now has to pay you $1,000, and now the patient's upset because they're like, wow, I just paid this to get my sleep study done. I already paid $500 or $700 cash. Now you're telling me I have $1,000 deductible plus co-insurance? So understand, and it's something that I teach our accounts, and a good billing company should understand this too and teach their accounts the same thing, that the insurance should dictate the path of the sleep study referral. You have to have a diversity of different referral options in your office. You have to have an in-network lab you're working with. You have to have an out-of-network lab or out-of-network national home sleep testing company. Or if it's in certain states where billing is allowed, sleep testing billing is allowed in your state, you be the out-of-network provider for that sleep test. At the end of the day, everything that the patient goes through should go on the same side. It should either go all in-network or it should go all out-of-network. And that's going to maximize the reimbursement for the practice, and it's going to minimize the patient's out-of-pocket costs. And again, we go back to capture rate and doing the right thing for the patient. So you have to be intelligent with the way you send your sleep study referrals out. And in my opinion, a billing company should get their hands on your patient's insurance information before that goes out anytime, because that's going to decide where that patient is going to be referred to. So, for example, if I get a patient and the patient needs a sleep study, our accounts give us the information. We do a benefit breakdown. We send that back. If you can get gap coverage, hey, great. Send it to ABC Sleep Lab that you have that great relationship down the street. You got gap coverage on this one. Let's go all in network on this one. Okay, on this one came over, another patient B comes over. We fought hard. We tried to get gap. It's not in their policy. We get the patient on the phone. They're not going to approve gap on this one. Let's make sure we do the sleep study as an out-of-network benefit with an out-of-network company, so it's the out-of-network benefit level, so that we minimize that patient's out-of-pocket cost and we maximize our reimbursement. So it's something that a good billing company understands that, and it's something that we really teach, that our practices let the insurance dictate the path of the sleep referral so that it's fair to the patient and it maximizes the practice's reimbursement. And then again, what if gap isn't available? If the patient hasn't had a sleep study, make sure they have a sleep study with the out-of-network provider. That's what I just said. I do that quite a bit, sorry.
You're fine.
I told you, Courtney. Gap or in-network exception is available. Send patient to the local oral appliance sleep lab that is in-network. Again, make sure that before you ever send a sleep study to a lab, make sure that it goes the right way. Also, make sure that sleep lab's oral appliance friendly, that they're not going to titrate your patient, put it on a CPAP. So before you start sending referrals over to the sleep lab, always do your homework on the sleep lab. Find out if they're in-network, out-of-network. Go have a meeting with them, find out if they're oral appliance friendly, test the waters with them. Don't send them 10 patients all at once. Send them a couple. Make sure you get those patients back. Make sure they didn't get titrated. Make sure they didn't go on CPAP when oral appliance could have been first-line treatment. And then back to patient deductible will land on in-network side for sleep study and oral appliance. Next. Gap or in-network not available, basing PPO coverage. So if you can't get it, you're sitting there like, say, again, basic coverage, $1,000 out of network with a 60/40, versus a $500 when 100 met, and co-insurance at an 80/20. go ahead and go next on that one, Courtney. So we kind of looked at that. So patient is referred to an in-network lab and gap wasn't available. Patient will have to pay roughly $600 to $800 to the lab, and that patient payment eats up the in-network deductible, and again doesn't eat up the out-of-network deductible. Patient will now have to pay another $1,000 plus out-of-pocket for the oral appliance because no gap was available, and the patient had the sleep study done at an in-network lab. Again, a good billing company will teach you this before you venture into this water with every patient. They'll get you the benefit breakdown so you understand completely what to do, step A through Z, with every patient that comes across you. Patient advice: be diversified with your options to refer sleep studies. Find a local in-network sleep lab to work with, and also find an out-of-network lab or national sleep HST, home sleep testing company. Some states, dentists can give the test themselves and bill for it out of network. And I do have some practices that do that. It's basically like they just include that as a treatment plan. So if you have your own HST and you can do that within your state, you pre-auth it first, because you have to pre-auth every HST, at least check for if a pre-auth is needed. And then when you go to bill that, you're going to bill the HST. It's a treatment plan. So the patient may have that large $1,000 out-of-network deductible. They may have a 40% co-insurance. But that also includes the sleep study, the board-certified sleep physician reading that sleep study. So you package that as a treatment plan. And again, we talk about turning it into a positive. So hey, we have great news. Your insurance covers the sleep screening. Your insurance covers the treatment. And then you package that as their patient's out of pocket, maybe $1,300, $1,400, but that includes everything. The oral appliance, the sleep study, the consultation, the panos, the x-rays, and you build value in that treatment plan so that patient understands there's a lot of value in that. So it may have that $1,200 or $1,400 out-of-pocket cost, but there's true value in that payment they're giving you. And again, that's beneficial for those practices that understand that hey, I got to go stay in network or out of network, case-by-case basis. So patient liaison, this is one more thing I'll talk about. Back to a good billing company. If you do have some patients that really don't understand medical insurance and they want more details than the provider, the dentist office can offer, make sure the billing company has that option for you, that they'll get on the phone with the patient and explain the patient's benefits to the patient so that the patient's comfortable to move forward with treatment. That should at least be available. Most of the time, it's not used, but it's, here and there it's needed and should be offered. Following claims, now it's all getting the patient in and doing the right thing. Now following claims, make sure you're getting paid for all this hard work that you're doing. What is the protocol for the claim submission follow-up? That's the biggest thing with personally, again, I learned this the hard way, kind of like I did with Medicare 8-9 years ago when, I was introduced to medical billing. I was on the operations side, and I included medical billing on that side as well. We didn't have a good system, and we were billing internally, and, we were treating like 10,000 patients, so we had a lot of flow coming through. We did not have a good system for following up claims and working denials. Everybody does submitting the claim. Everyone kind of by nature does what's in front of them. But the billing company you work with should have a system in place that, they follow all the claims and they work those denials when the insurance does want to play games, even if you got an authorization, even if sometimes the insurance, goes to the wrong department, or you got gap approved and they paid it without the gap approved, and you got to go back and fight that. There has to be, your billing company that you work with has to have a plan and a system in place to deal with all that. We have, and for our staff here, I've figured out through trial and error, through years and years, that our account managers are going to be focused on working with the accounts and working with capturing the patients. So all this stuff we just talked about is what our account managers do here. I know that the account managers aren't going to have time to follow claims. So we have separate staff, a separate division that does nothing but claim follow-up so that it doesn't get ignored. Because if it gets ignored, it can go 3-4 months without getting paid, and nobody knows until it's an issue. It shouldn't be like that. You should know right away if the claim is at least being processed. If it gets denied, you may have to send a corrected claim. You may have to work that denial, but you should at least know it's in there and being processed. So there should be a protocol with whatever billing company you work with. They should have a protocol in place. It should be a minimum of 2 weeks after the claim has been accepted to confirm processing, and then weekly after that until the claim is paid. So what happens is a billing company uses a clearinghouse. It goes to the clearinghouse. Some clearinghouses are better than others. It goes to the clearinghouse, and then the billing company will get a report of all these claims that have been accepted or been failed. Once those claims have been accepted and they go in to be processed and they're in for adjudication, that's not the end of it. That doesn't necessarily mean it's going to be paid. It just means the claim was clean enough to be accepted. It doesn't necessarily mean it's going to be paid correctly. So there has to be that protocol and system in place to make sure the claim is being processed in a timely manner and that it's going to be processed in the right way. And if it's not processed in the right way, that you're turning it around, sending a corrected claim as soon as possible, that you're getting wind to that. Because if a billing company waits for the denial and the denial letter to go back to the provider, and the provider maybe gets lost in the mail, it gets lost in all their work, they never send that to the billing company, it's just a mess. It's just asking for delayed payments, months and months of delayed payments if they don't have a good system in place following claims. So that's a real important thing. If I'm out there shopping a billing company and I'm a provider, it's going to be something I bring up quite often. And also another benefit to this, if they're doing a good job following the claims, they're going to find out if the patient received the check. And again, trial and error for me years and years ago of not knowing my patients were receiving checks all the time because we weren't aggressive with our claim follow-up. Our goal is to have that claim follow-up and to get that information to a provider before the check's even been sent to the patient or within a day or two from the check's been sent to the patient, so that the provider can contact the patient and say, hey, look, a check is on its way, or you're going to be receiving a check, or we know you just got a check a few days ago. That's a big difference because the patient gets that, $2,000 payment in their hand, and most people have a decision to make, and most people are honest and they'll get that payment to you, but some people let that money sit in their bank account and wait for you to come collect it. And the longer that sits in that patient's hand, the longer, the least chance, the less chance you're going to have to collect that that revenue from the patient. So it's critical that when we follow claims that we're also getting that information to our providers that, hey, the check has been cut, it went to the patient yesterday, 2 days ago, contact your patient right away before they spend that money. It happens, especially this time of year. Everyone's got Christmas stuff to pay.
Right.
It's funny how often that happened at this time of year. Actually, not funny. It sucked. Weekly or biweekly reports. Billing service should be sending a weekly or biweekly report to ensure where each patient stands in the process. So you guys, the other big complaint I've received from getting billing clients over from other billing companies is they always feel like they're in the dark. They don't know where their patients are in the process of things. They may have sent 10 patients in the last month or 20 patients in the last 2 months, and they have no idea. Are they in the auth process? Are they, are they still waiting for further documentation to get the auth process started? What's going on with every patient? So a good billing company is sending out a report to show where every one of your patients is in the process. It doesn't have to be an extremely detailed report. I found that giving them too much information once they get some volume is overwhelming. It's basic, like it should just be a basic categorized report. This patient's waiting for authorization. This patient's authorization's been approved, or we're waiting for waiting for a claim submission from the office to the seating of the appliance or the TMD therapy or whatever it is. We're waiting for dates of service, or this column could be this column would be this patient we're still pending further documentation from the office to get the approval for the authorization approved. So it's very basic. And yeah, here's an example of one. I'm sitting here looking out the window talking. It's right in front of me. Yeah, so you can see on the top part of here, this is the one that we send over. The claims that are billed out, we pull this up in an Excel spreadsheet. We export it from our clearinghouse, and then there's a lot more information on that from our clearinghouse, but we delete those columns, put it in this, so you get a snapshot of where your patients are. And these are just samples. So this one has like four claims that have been passed, and they're in submission right now. You can see on the far right, they've been accepted by the insurance. And then down here, I have auth needed for HST, a couple patients, pending auth for HST, auth gap, it's hard for me to read, this is small, needed for E0486, pending E0486 auth, and then waiting for direction from the office. So that could be waiting for paperwork or waiting for the direction from the office to say, yeah, we've seen the patient. So it's basically a snapshot that goes out to our clients that shows where their patients are in the process, so they never feel like they're in the dark. And we send that out weekly, bi-weekly, depending on the volume of the client. Am I running out of time here?
No, you're good.
Are we allowed to go over?
Yeah,
Okay.
Of course. Yeah, you're good.
I think we're almost done. This is like 26. I think we're almost done.
Just one more slide.
Okay. So rates, make sure you negotiate a cap if you have on a percentage. There's different things out there for rates. You have percentage on collection. You have percentage on allowable. So those range anywhere from 7 to 12%. Sometimes I've even seen higher. So you have percentages on what's being paid or what's being allowed by the insurance. We work on a flat rate. So that, we work on a combo. On sleep is a flat rate, on TMD is a percentage, but make sure you negotiate a cap regardless of whatever you go to. Look at what's best fit for you, whatever you think is fair on your rates and what's competitive out there in the market. And but at the end of the day, my advice to you, because I've worked with other billing companies, and ours is $250 A to Z for sleep patients. That's because we credit back the pre-op and the gap coverage, the $25 patient setup fee, we credit back. So ours is real basic, and it's a flat rate, $250 on PPOs, $99 on Medicare and any HMOs that you're in network with. But other companies out there, they can work on like a 8%, 9%. I used to work with a company a long time ago that worked on that percentage, and we would get a good payment from the insurance of maybe over $3,000, $4,000, sometimes up to $5,000 for everything included, and we would charge the client like $450 for one patient billing. And to me, that's excessive. It was very excessive, and one of the reasons I made a move from that company because it's not the right thing to do. You should negotiate a cap that's the maximum you pay on a patient is anywhere from $250, $300. So if the insurance pays you well, the billing company didn't do anything more than it did for any other patient. It's just that insurance had a higher allowable. So my recommendation, whenever you're shopping a billing company, whatever you're doing out there, they may work on a percentage, but tell them, look, okay, I understand the percentage is what it is, but there should be a cap involved. You shouldn't charge me more than whatever $300 or $275 per patient, because again, in my opinion, to my experience, that's excessive. And I know there's a lot of companies out there that do that. They'll charge, I've seen $450, $500 for one patient billing, and to me that's honestly ridiculous. It should be something that's fair, something that helps grow that provider's practice. So definitely negotiate a cap when you're doing that if you do decide to go with a company that is on a percentage basis. Last thing, this is my last slide, right, Courtney?
It is.
All right. HIPAA communication. So last and probably most important to protect your practice, make sure that they're not just, your billing company is HIPAA compliant. Because I hear stories out there, hey, fax us over the documents and we'll send it back to you. And there's practices and billing companies using regular emails. That's a big issue if a provider is caught doing that, and big fines. There can be tremendous fines out there for HIPAA violations. And everybody hears about all the hacking, and I guess the celebrities just got hacked, and everybody's getting hacked. make sure that you're doing everything, whether your patient's information gets hacked or not. It's what you're doing, your due diligence as a business, as a provider, to protect your patient's information. So, and if you're working with a billing company that's not using HIPAA-compliant communication methods, stop. Don't do business with that company, or don't get into business with that company. It should be there should be HIPAA-compliant emails. Any email correspondence going back and forth should be HIPAA compliant. Or if they're going into your software system, it should be a secure portal. It should be a HIPAA secure portal that's going back and forth in there. So, and that's usually very safe when they can just tap into your system and go into your system. But if they are going to communicate via email, and and I bring this up because this is the big mistake I hear about there and I see, and we've even had accounts send us patient information via email, and we say, hey, stop, don't do that. We'll give you a HIPAA email account so you can send it over this way. Make sure your billing company offers that service. Make sure that they're 100% HIPAA compliant, and all communication going back and forth between you and the billing company is HIPAA compliant, so that you don't get burned for your part if there's fines coming down, that billing company gets audited and they have, 100 providers that they're working with. Wow, guess where that chain's going to go to? It's going to go to all these providers that are going back and forth, and everybody's going to get that good old fine. So a high recommendation to make sure that you're working with a billing company that's 100% HIPAA compliant.
Great, thank you so much, Randy. What I'm going to do at this point is go ahead and unmute everybody's lines. If there's anybody that wants to jump on the line and ask Randy or any of the Nierman team here a question, feel free to just jump on the line. You'll also find a chat box in the lower right-hand corner of your screen if you'd prefer to type your question. We'll make sure we read any questions that are down there in the chat box as well. So if you don't wish to be unmuted, you can feel free to just mute yourself right back. You'll find a microphone button next to your name on the participants list. So in about 3 seconds here, everybody will be unmuted. Anybody with severe background noise, I'll go ahead and mute back. All right, so anybody on the line have any questions or comments they'd like to share? You know what, we actually have a couple in the chat box. First question is, what software do you recommend for HIPAA compliancy?
What software to recommend for HIPAA compliance? Dental Writer. What other software would I recommend? Our software. We're 100% HIPAA compliant.
We got an LOL out of that in the chat box. Another question from the chat box here. Are you able to get UCR from carriers?
No, it's hard to get, as an out-of-network provider, it's hard to get UCR from the carrier. What we do is we rely on our experience for different regions and different areas to get to really understand what the UCR is and the allowable is going to be. But it's very difficult to get the exact UCR as an out-of-network provider. Sometimes you'll get those negotiation letters and things like that you can get on the phone and talk to the person on the multi-plan side of negotiation, can kind of get what the UCR is. But the answer would be no, very unlikely for us to get UCR.
Yeah, and I think that's a good point too. A lot of out-of-network providers are looking for that secret on how do I find out the UCR. And I think one of the big benefits, of course, of working with if an outsourced billing service is something you're looking for, that they have these billing services have experience, within or at least close to your region, to be able to provide a better estimate to the patient. Because without having any idea, of course, it's very difficult to give them an accurate estimate. It's just pulling numbers from nowhere without having any previous experience in that region.
Yeah. And I did want to mention before we go further too, on that when I'm talking about negotiating your rate, like a $300 max on that rate, mostly pertaining to like sleep appliances. If you're doing if we're talking about oral surgery, and yeah, you're billing out, it's extensive work to get that approved, and you're billing out a larger amount, it wouldn't be a cap on that. So it depends what you're billing out. And when I was focusing on the cap there, most of that I was talking about is dental sleep medicine. But because with oral surgery and other things, it's a lot more intensive for the approval process. So that's a hard one to get a cap on.
Great. Another
Any
question. Oh,
questions?
sorry, go ahead.
Any other questions?
We've got one in the chat box here. Can you tell us if Medicaid covers home sleep tests?
I believe Medicaid does cover it. Do they cover it to the dentist? If a dentist is doing it, I've never been able to get one approved, and they follow Medicare guidelines, so I never would do that. But Medicaid would cover it to a sleep lab. So if you have a Medicaid patient present themselves who needs a home sleep test, you would either send that to a oral appliance friendly sleep lab in your area to get that done, or you would contact, there's a couple different national companies, Home Sleep Test LLC, another company called IDS, Instant Diagnostic Services, where they would work with you to treat those, get those Medicaid patients sleep tested.
Great. All right, we do have another question in the chat box here for you. Do your claims go on paper or electronically? And do you send the supporting documentation with it? For example, CPAP affidavit, out-of-network referral, prescription from the physician, things like that.
Good question. For the most part, all of our claims go electronically. And to get the documentation over to the insurance company, we do that during the pre-auth or pre-cert process. If no pre-auth or pre-cert is required, we will still sometimes submit the claim electronically and then fax over all the supporting documentation so they have it on file when they go to process the claim. But there are times when we drop it to paper. We will drop it to paper if the provider is new with that insurance company and we want to attach a W-9 and maybe in some enrollment forms from their website and submit that with the first claim as well, including all the supporting documentation to get the first one in the system and process and get the provider, say, for example, in network, or not in network, but in Aetna's system to be a provider. It depends on the case, but most of the time, like 90% of the claims we send out goes electronically.
Great. All right, we do have another question here in the chat box. Does Dental Writer do the HIPAA compliant email system? And if so, where is it at? That's a great question. I'll take that one.
You go.
Basically, currently there's not actually like a built-in just email HIPAA account. But the great news is any HIPAA compliant email program that you choose, I know there's different preferences out there because there's several different options. But whatever default email system is set for your computer, for your system, Dental Writer will use that in your email triggers. And our billing service here does use the HIPAA compliant email. What type of email is that again, Randy?
It's called MD Office.
MD Office. And so there you go. There's lots of different ones out there. That's the one that we've selected. So when you receive any communication from our billing service, there to your office, it'll be through HIPAA compliant email. And the great thing is you don't actually have to when you receive one, it'll have you just log in with a little free account and you'll be able to even reply straight from that system to our billers securely as well.
Yeah, and we offer that. We do the whole setup, all of our accounts. We offer that HIPAA email for them. It's all, our domain is HIPAAmail.net. So they basically put their provider, their business name at HIPAAmail.net. Everything that we correspond back and forth goes through an encrypted email.
Yes. Exactly.
All right. Well, great questions, everybody. Anybody else on the line have any questions or comments that they want to address before we finish up here?
Well, Randy, this is Rose, and I just wanted to say that was such a great webinar and so much education there. And well done. And Very well done.
Thank you.
Agreed.
You're welcome. And I'd like to just make sure before we get off that I wish everybody a happy holiday as well.
Yeah, you know
If
what,
we
great
don't-
reminder, Rose. This is the last study group of the year, so thanks to everybody for all your support throughout 2014 and keeping this study group alive and fun. So we've had a great year. We'll of course pick up again in January, and you'll get your usual weekly invites and reminders. So again, thanks for all the support throughout the year as well. All right, and if there's no other questions, keep in mind too, we've released our 2015 CE schedule with some really exciting new courses and education paths too. So you can see the whole schedule and our speaker bios and all kinds of fun stuff on dentalwriter.com, or of course feel free to give us a shout and we can help you pick out an education path.
All right, well, thank you everybody so much for attending.
All right, bye guys.
All righty. Happy holidays
Bye-bye,
to
everyone.
everybody.
Bye Randy, thanks.
Bye-bye.
And thank you again, everyone. Thank you. Bye-bye.